Good afternoon, morning, evening, it depends on where you are, everybody. My name is Paola, Paola Saccomandi from Politecnico di Milano. I am the chair of the Technical Committee, Therapeutic and Diagnostic Systems and Technologies. And today I have the pleasure to introduce you a speaker, Professor Lorenzo Crocco from the Institute for the Electromagnetic Sensing of the Environment, the National Research Council of Italy, in the framework of the webinar series that our TC is organizing. And today, thanks to Lorenzo, we have the second webinar. So I'm very happy to have you, Lorenzo, with us. Let me say a couple of words about you, even though a couple of words won't be enough. So the main scientific activities of Lorenzo Crocco concern electromagnetic scattering with a focus on diagnostic and therapeutic use of electromagnetic fields, non-invasive electromagnetic inspections through the wall radar and GPR. He has published more than 100 papers, given many keynote talks and lectures. Also, I did 2 books on medical applications of electromagnetic technologies. Since 2021, he is among the world's top 2% scientists, and he has served as associate editor for the IEEE Journal of Electromagnetics, RF, and Microwave in Medicine and Biology. And he is also Italian representative in the management committees of Cost Action, which is devoted to medical applications of electromagnetic fields. Lorenzo, I would like to leave the floor to you, to your presentation, your webinar about the topic, Introduction to Microwave Imaging for Medical Diagnostic and Monitoring. I would like to thank all the attendees, and at the end of the talk, we will have enough, I hope enough time for Q&A session. So, Lorenzo, I leave the floor to you.
Okay, thank you, Paola. Thank you very much for the very nice introduction and especially for the invitation to hold this webinar. I have to say this is, I think, my first experience at a worldwide webinar, so I'm quite excited about this opportunity, and I will try to stick on the times and leave enough time for questions. But let me just start the talk showing you the Vesuvio, which is the famous volcano and mount from the town which I belong to, which is Napoli. You see it today with the sun and the clear sky, and today is with the sun and the clear sky, but there is some snow because today is very, very cold also in Naples. So as Paola said, I come from the National Research Council of Italy, the Institute for Electromagnetic Sensing of the Environment. We are based in Napoli, in the south of Italy, but we have also secondary units in Milano, in Bari, and an experimental unit in Lago del Garda, a very nice place in the north of Italy, close to Paola, by the way. And the Institute covers very many topics about sensing, electromagnetic sensing. In particular, I started working with the Institute when we started the electromagnetic diagnostics team, covering a number of topics on sensing, radar sensing, microwave and terahertz sensing, optical sensing, for different applications. And in particular, since I think now, I don't remember how many years, I think 15 more or less, we started a line of activity on clinical and diagnostic therapeutic application of electromagnetic fields. We are quite a group of researchers, of staff people, and there are also students, a PhD student working with us. So to bring all these research lines. And today I will share all these applications, they share the main methodological tools. And today I will start giving you an overview of the tools and then, as I said, the application in medical imaging. So let me start very briefly with what is and which are the basics of microwave microwave tomography. So microwave tomography is essentially a phenomenon which occurs, a technique which is based on a phenomenon which occurs when an electromagnetic wave produced by some known antennas hits a target and produce a secondary field. We talk about microwave tomography or microwave tomography when we are in the microwave frequency range, which broadly covers from hundreds of megahertz to tens of gigahertz. Of course, there is no exact boundary between lower frequency and millimeter waves, but these are more or less the frequency I will mostly stick to, and mainly in the hundred of megahertz and gigahertz region. So what happens when a known field called the incident field hits a target is that this field, which is the total field, becomes perturbed by the presence of the target. And you see that though we start from an incident field, which is produced by these transmitting antennas, and then we have a field which is the total field, which is the perturbed version of the incident field. The scattered field is the variation due to the target. And in fact, this scattered field depends on the kind of target. For instance, if we change the size or the shape, or even maybe the distribution in space or its electromagnetic properties, we have that this scattered field that you see here, it's basically the footprint of the target. Every target has a different footprint arising from the scattering equation, the electromagnetic scattering. So we can take advantage of this concept by measuring the scattered fields and by processing in some way, and therefore we can get information and especially create images of what? Of the morphologic, I mean the shape, the position, and the electromagnetic properties of the target of the scenario under consideration. This is the very basic concept underlying microwave tomography. It's, of course, as a mathematical formulation, which is briefly recalled in the next slide, and I swear it will be the only mathematical thing I will show today. The problem formulation is basically cast in terms of two paired integral equation. We have one, I have highlighted in green the known or measured quantities, and in red the unknown quantities. So you can see easily that the equation are paired by means of this term, and also that the pair of equation as a whole is a nonlinear system of equation, because the total field and is related to the contrast and in a nonlinear way. So the contrast, I named the contrast, is one of the important names in this story. It's the contrast function. This is the real unknown of the problem, because this embeds the electromagnetic properties of the targets, and I mean the electrical conductivity and the electric permittivity, with respect to the host medium, so the medium in which the target is embedded. This is, I say, this problem, you see, it's a nonlinear problem, because if you want to recover the contrast from the data, which are the scattered fields here, you need to know something which depends on the contrast. But what is worse is that due to the properties of the integral, this is also a kind of smoothing filter moving from the right-hand side of the data equation to the data. And this means that this problem is ill-posed. So very, very quickly, I'm saying that the main difficulty in dealing with microwave tomography, or at least one of the main difficulties, is that we have to solve a nonlinear and ill-posed EMBS scattering problem. I mean, I will stop here. Of course, there is a huge world of mathematical tools and theories about ill-posed and nonlinear problems, but I will skip them, looking at how we can use these concepts and tools in medical application. In particular, to do this, but it's important to figure out what is a microwave tomograph. So what is the tool that we use for microwave tomography? Basically, the tool is made by, assuming this is the target we want to image, we have an emitter or a series of emitters, which are transmitters producing the incident field. Then we have some receivers which receive the scattered field, that is the perturbation of the target due to the perturbation of the incident field due to the target. These are all acquired by a very compact device, which is called a vector network analyzer, typically, which allows to measure both amplitude and phase in general, synchronized of all these fields. And then all these data are provided to a data processing algorithm. The data processing algorithm has the task to take the scattered field data and extract an image which depicts the dielectric permittivity and electrical conductivity of the target. So, and of course, as I said, the shape. So when we have, this is, let's say, the backbone of any application of microwave tomography you will see around and you will see in this seminar. And it's worth to say that there are basically, among the many, two problems associated with this. The one problem, I would say, a kind of hardware problem, which is we need to make these systems accurate and non-redundant. So we need to design systems which are able to get the information, the scattered field in the condition we want, and also that are non-redundant, meaning that they are minimally complex systems in order to have economicity and effectiveness. On the other hand, the other problem, which I would call a kind of software problem, is to move from the data to the image. We need to solve the inverse scattering problem. So we need tools to solve reliably the inverse scattering problem. And this is, of course, a quite complex task, which is common to many imaging applications. So I'm sure you are aware, many of you are aware in their own respective fields. But in the microwave imaging, we have this problem, of course, due to the ill-posedness of the inverse scattering problem. So now, why this concept is possible in medical diagnostics? So basically, this concept is possible in medical diagnostics due to one circumstance. The circumstance is that the electromagnetic properties of human tissue change according to the tissue type and also the pathological state, for instance, LTO tumor. Just to give you an idea, for instance, this is the comparison between, again, the dielectric permittivity here and the other parameter, which is the electric conductivity for liver tissue. Liver tissue, in this case, you see the red one is tumor tissue, the green one is healthy tissue. You see that there are differences between healthy and tumor, meaning that there will be a contrast in, for instance, a liver which is suffering of tumor, of the area of tumor with respect of the area which is healthy. And this happens also, for instance, for the brain. This is maybe more hard to see, but you see that the very different tissue of the brain offer different permittivities. And also, in particular, one I will talk soon about this application in the breast, where the normal tissue is separated from the tumor in terms of permittivity and conductivity. So the important thing is that the electromagnetic properties of human tissue change. And in fact, there is a broad literature on this topic. You can find it dates back to the 1951, so very long time ago. And indeed, you can find very, very seminal studies from Gabriel and Gabriel, where all the properties have been measured. These are measured non in vivo, but ex vivo. And then my colleague from the Institute IFAC in Florence, they also put an applet online in which you can just put the tissue you want and you can have all the information about the tissue. And this is very convenient if you want to have an idea of how do the tissue change in time. So the question is then, we can differentiate the tissue depending on typology and pathology. And so we can fix, which is the aim of microwave tomography, which is creating images of electromagnetic properties to determine the physiopathological state of this tissue. Why microwave imaging is attractive? I will come later more in detail on this, but the attractive part is that this is a very low risk technology, because the microwave tomograph requires very low power microwaves, and as also microwaves are non-ionizing radiation. So we are avoiding all the risks of, for instance, CT or X-ray. On the other hand, the microwave imaging takes advantage of all the technological tools developed for the widespread communication technology, and therefore they are very cheap, very miniaturized, and this means that this technology is potentially low cost and portable. So these are, I think, the main point in favor of this microwave imaging, and I will show you later how does it takes practice in the application. But the concept of different EM properties, as I said, is a long time concept, and this is why, I mean, it's worth in an overview to report which are the first results, which dates back to the late 70s, in which Larsen and Jacobi made an image of the kidney of a dog. This is the wave, guys. So with respect to my scheme, this is the transmitter, this is the receiver, and this is the target. And they move this transmitter and receiver along the target to create, in a raster scan modality, to create images like this. The interesting thing is that this image is well correlated with the physiology. So they have an interesting feedback of what's going on. Also, in Europe, there was some work like this, which was done especially by Professor Bolomé at Supélec in Paris, where he developed a camera, which is this one. Again, you see the transmitter, the receiver. This is a retina of receiver you see here. To image, for instance, the hand. They made a proof to make real-time imaging of the hand. These are the hand which is moving. Of course, this is a snapshot, so it's not possible to appreciate. But it's very interesting. They choose the hand, and I think it's a very nice choice. I think they did it on purpose, because you know very well that the first medical imaging is the X-ray image of the hand of Anna Röntgen. And so it's nice, of course, possibly unfair for microwave imaging to compare these images and see how do they how do they look like. You can see that there are, of course, a very different capability of microwave imaging in terms of spatial resolution. And this is, let's say, I would say obvious, because the frequency is much lower, and the frequency affects the spatial resolution, but also the fact that microwave imaging gives more images maybe of soft tissue than, for instance, X-ray does. And also, moving from image C to D, it's also important to see how the algorithm, are the raw data, while the raw data are transformed into these images thanks to the algorithm. So, as I said, the important part of the algorithm, microwave imaging. But this was just a way for me to summarize which I think are the pros and cons of microwave imaging, and what are motivated so many scholars around the world to work on that. Basically, this is, as I said, a safe technology. It's also potentially capable of giving quantitative information, so discriminate among tissue, and also is low cost and portable. Also, the very early examples I showed before, they are very small and cheap systems. Then on the downside, we have, of course, spatial resolution. And the other thing is that the penetration in the human body is to some extent limited, and more limited the higher the frequency we consider, due to the fact that water attenuates microwaves. But in any case, a very large number of applications have been considered for this topic, which are listed here from, let's say, I would say the most exploited and most famous one to, let's say, more emerging one, like, for instance, treatment monitoring or a trauma. I will not cover all of them during the next slides. I have concentrated on three of them. The one, of course, I started with is breast cancer, because it's the one which has been mostly studied through the years. Then I will consider the problem of diagnosis of brain stroke, which has also been quite popular, and a lot of scholars have considered that. And then I will provide some of our recent work on treatment monitoring, and in particular with the microwave imaging to monitor thermal treatment. So let me start with the first application. which, as I said, breast cancer. The motivation for studying breast cancer is quite obvious. I say this is the most common cancer in female population, and also, like most of cancers, early detection is crucial. So any effort to improve the fight against breast cancer mortality goes through the need of detecting the cancer early. And of course, this is what current modality have done, decreasing in a significant way mortality due to the cancer, but still they have some I wouldn't call them limitations, some small defects. As far as the first level screening is concerned, X-ray mammography has, of course, the excellent capability of getting 19% or even more of cancer nowadays and being very easily accessible, but it uses ionizing radiations, which is, of course, a downside, and also somehow is painful for the patient, for some patients due to the compression, and not always the diagnosis is reliable for younger, which somehow conflicts with the need of doing the diagnosis early. On the opposite end, there is magnetic resonance imaging. I would say the queen or the king of magnetic resonance of medical imaging techniques, but due to its excellent sensitivity, spatial resolution, but it's obvious that the accessibility of this technology is still low nowadays, and morphological diagnosis is somehow the main scope, not the functional one. This is why the fact that there was a contrast between, as I showed you before, between tumor tissue and normal tissue motivated some scholars to consider the use of micro tomography of breast cancer. So the concept in this case, it's shown here, and it is basically the one which is exploited in most of the studies I will briefly cover here. It's that we will have the woman lying on a bed and the breast being circumvented by antennas, which will probe them according to the microwave tomograph principle. This is actually a figure coming from a work by Professor Paul Mini, which was indeed the pioneer of this technique. And indeed, the first image in this sense I would like to show is the device, the prototype device, the prototypal device developed by his research group at Dartmouth College in the USA, in which you see all these antennas are dipole antennas radiating. One important thing I want to point out that you don't see here, but the antennas are all immersed in a water tank. This is because one important aspect of microwave imaging technologies is to have a good coupling between the incoming wave, the incident field, and the human body. And as we are mostly made by water, or in any case by high permittivity materials, this is why most of the devices, they make use of some matching liquid to enhance the penetration in the body. This is the first, I would say, example of breast cancer tomograph, followed by the one developed in Bristol by the group of by the Bristol University. And this is, in this case, you see, these are different antennas. They're not animal, but they are printed antenna, but the concept is the same with the patient lying on the bed. More recently, a French company called MW Vision developed a system which is called Wawelia, which is now undergoing, like the other one, clinical trials. And this is maybe an effort, a step somehow, of course, many years after, with respect to the other one, because there was an effort not only on the hardware part, but a lot of also on the imaging part, as I said. So the effort was to create images which were more compliant for the medical community. And another and maybe the last example is the system developed by an Italy-UK company called UBT, which developed the MammoWay system. And again, also in this case, there was an effort on the hardware, but also on providing images which were possible to correlate with medical images. However, and since my intention here is to give an overview, these are very excellent and important works. But maybe one normal question would be, there is no breast cancer microwave imaging unit in any hospital. The reason why is that, of course, the progress is slow, also because there are, as I said, excellent technology, but also because maybe the problem with respect to the early time when it was started is not so immediately solvable, in the sense that if we have a closer look at the contrast between tumor tissue and normal tissue, we understand that as long as the tumor is in fat, we have a very large contrast, 10 to 1. While if the tumor is located, as in most cases, close to the fibroglandular tissue, we have a smaller contrast. This is why my research group, together with Federico II University in Naples, we started developing another technique, which was aimed to counteract the fact that there was a low contrast, which means false positive and negative with a higher rate, and also low useful signal, which means that the signal to noise ratio is very challenging, so very difficult to measure the signal. So the idea we developed was basically to consider the fact that instead of moving to a simple imaging, this is of course an increasing complexity, not trivial with respect to the other I showed, but in this case, since the idea is to make some contrast enhanced tomography, and the idea was to use, when we started, I mean, kind of more or less 10 years ago, thinking about this, there was a race in the medical community about, important race about magnetic nanoparticles, and the idea was to use them as a way to enhance this contrast also for the microwave imaging, with a very special effect, because considering the fact that nanoparticles are already approved in the practice and they can be functionalized to go in the tissue in a very selective way, they have two very interesting properties. One is that they produce a magnetic contrast, which is unique in the body. So there is no magnetic contrast in the body unless the nanoparticles tied to the tumor. And the other thing is that they are sensitive to the magnetic field, to an external magnetic field, meaning that they response, I mean, this graph here represents the response of a ferrofluid immersed in a waveguide here, when the magnetic field here is changed in intensity. And you see that changing the intensity, the response of magnetic nanoparticle changes. So the idea was to enhance the microwave tomograph with a magnet outside of it, which was either switch on and off. When the magnet is switched off, then the nanoparticles, they have some response like this. This is an hysteresis curve with respect of magnetic susceptibility, real and imaginary part. But when the magnetic field was switched on, then the magnetic nanoparticle switched off. This is basically what I show in the previous here. You see, for instance, if you change it here from the blue to here, so you switch off the nanoparticles. And this is very convenient because it means that we can create a differential technique between the two measurements in which the only thing responding was the tumor. Once, because the nanoparticle react with their magnetic contrast, and then there was only the background response, as if the nanoparticle have been removed. We made also some experiment with a very similar system with a breast phantom, and we observed that indeed there was a good detection of the presence of the nanoparticle mass. This is just the received signal. With respect to the presence of nanoparticle mass, of course, there are problems when it's zero because there were some hysteresis, but still you see that it's possible to detect the cancer with this, detect and then image the cancer with this concept. So I move then now to the second application. In this second application, it's about the diagnosis of brain stroke. Now, brain stroke is a very, very, very important medical problem as well, because I would say, everyone knows somebody who has suffered a stroke. This is because the occurrence, the epidemiology is incredible. Every 3 seconds, someone has a stroke. And this means that there are a huge number of cases, and especially in low and mid income countries where it's very, very difficult, if not impossible, to have a diagnosis and the medical treatment. This means that the causalities produced by this are very high. But the question, the medical need, I would say, the question here is that the main point when facing a patient suffering stroke is that the stroke is not just one pathology, it's actually two pathologies. We can have a stroke due to ischemia, which means that there is no flow of blood to the part of the brain due to a clot, but we can have a stroke due to a hemorrhage because there is a vessel which is still starting bleeding, and this blood creates a problem in terms of intercranial pressure. And despite the fact that they are not the same in terms of presence in the population, the very difficult thing is that their treatment is opposite. In one end, you need to stop bleeding, you need to favor the blood and the blood flow, while in the other, you need to stop bleeding. And therefore, it's essential to know as soon as possible which is the kind of stroke the medical doctors are facing. The current technique have, again, imaging technique have made a significant efforts to move this, but still you need to do in the hospital, meaning that the subject has to come to the hospital, and with a problem in terms of scanning time, the sharing of the facility, portability, and also the fact that there is no continuous monitoring. So for this reason, even if the stroke, of course, is well addressed in the medical practice, we can see that there are still demands, and there are still nowadays demands for in the medical community, which are basically, we would like to have a diagnosis before the hospital. And diagnosis means identification, there is a stroke, and classification, is it an hemorrhage or ischemic? And then another interesting thing is that, what about continuous monitoring? What about after the acute phase? This is because for two reasons. First of all, this is currently is not done. It's impossible to do it. And the second thing is that because of course they do it with images, so the only thing is monitoring vital parameters. And the other thing is that there are situations in which the treatment can bring the other kind of stroke to occur. So it's very, very important to have this one. For this reason, a number of microwave imaging can be useful in this concept. Why? Because for both the brain tissue, when there is no oxygen in it, that is when it's a clot, and when the blood, they have a different contrast, and therefore it's possible to use the concept of microwave imaging to try to address some of these concepts. This has been done, and it's nice to mention that there are products, or at least in their clinical validation phase. The pioneer one in this case is the one developed by a Swedish company, which is a spin-off of Chalmers University. It's called Medfield, and they concentrated on early diagnosis. It's not just imaging, just to understand whether the stroke is an ischemia or an hemorrhage. This is very important in countries like Sweden, where most of the population is scattered in a very big country, and therefore, before people comes to hospital, it may be too late for them to recover from the stroke. Other two companies are European, now US-based EM Tensor, which developed a kind of, I would say, portable system in which you have, this is the head goes inside here. There is a number of antennae, I think 128, which are also hidden inside a kind of coupling medium, and the head goes inside to produce images of the head. And they are running now clinical trials to see whether they are able to make diagnostic image of the patient with this device. And finally, EM Vision is an Australian-based company. They have a kind of intermediate concept between the two, because this is a sort of quite portable helmet device, and all the hardware is here. But again, they want to produce images of the brain like this. in this concept, these are very, again, no one of these is in the clinical practice, but all of them are running clinical trials. With my group, in collaboration with the Polytechnic di Torino, the group of Professor Francesca Vipiana, we noticed that no one of them was working on the idea of monitoring in the post-acute phase. And this is why we try to make a project, a design of a device which was able to make this monitoring and therefore make it in the bed, at the bed of the patient. To do this, basically, we need to make a very simple design, and we decided to make as much simple as possible. You considering a very small frequency band and making the device integrated with the coupling medium. This was a quite new concept we introduced with this device. So instead of having the antenna and the coupling medium, which was typically liquid one, we made a semi-solid coupling medium and integrated the antenna within them. So the first device, it's shown here. It's reverse because I will show you in a while. And so every one of this block is an antenna which embeds both the coupling medium and the antenna. And this mess of cables is that because we made the system simple, meaning only 24 channels, but still we need to make some effort in reducing this. This was our first system, and it's upside down because we filled it with mimicking media to observe the possibility of visualizing the stroke with such a very simple system with respect to the other one you saw. And we made some preliminary work, again, with phantoms, and it's possible to see that the stroke in different position was correctly imaged by the device. But as you see, the device was still bulky for the aim we put, and therefore we moved to a more refined solution in which the antenna were made even smaller and flexible, and the acquisition unit, the switching unit to change between all the channels, was simplified into this what is called correlator matrix. And we are not still very clean, but it's already a very big jump with respect to forward with respect to this. And with this device, we create a very complex phantom to make monitoring of a situation in which the bleeding, or I don't remember if it's the bleeding here or the ischemia, was either contracting or growing. And you see, so we fill this balloon and we perform the imaging task. And you see that from a situation like this, we move to this in the balloon, and the image of the head, they show what is going on. So first you have only this part which correspond to this, and then there is this part which correspond to both of them. So this is the part of the brain, and now we are trying to improve the system further. The last topic I was mentioning is about, it's a slightly different one, because in this case we are trying to have to consider the effort of microwave tomography not as a diagnostic tool, as I showed you before, and as I show you in many applications which have been considered, but especially as a tool for guidance of treatments. This is because this is possibly another place where the portability, the low cost, the non-ionizing nature of microwave tomography can be helpful in the development of this technology. And in particular, this is something we introduce, my group and the group of Professor Marta Cavagnaro in Roma introduced to the community, was basically the idea of using microwave tomography for monitoring thermal therapies, and in particular ablation therapy. I have to make a disclaimer here because Professor Bolome in the late 90s, I guess, made some experiment to measure hyperthermia, but it's a different kind of problem. So what is the thermal therapy we consider? The thermal therapy we consider is microwave thermal ablation of liver cancer. There are a number of reasons for this. The first one is, of course, liver is one of the most widespread causes of death and very spread cancer in our society. The other one is that typically until, I don't know, some 10, 20 years ago, 15 years ago, the main way to approach this tumor was surgery. But then the idea of thermal treatment was rising because thermal treatment allow non-surgery and non-surgery treatment, and therefore by increasing the temperature locally in the tumor could burn the tumor basically and kill the cancer cells. And this had improvement, a significant improvement. And the improvement was even more significant when the problem is how to heat. So initially it was used what is called radiofrequency ablation, using basically an electrode, but that could only burn very small tumors. When we go to solid tumor like liver, the need is to burn even larger ones. And this is where the use of a microwave applicator, this is really an antenna going inside and propagating the electromagnetic energy inside the tumor, increasing the temperature up to its level that it destroys the cancer cell, get a very big impulse for this technology, for the treatment of this pathology. But the problem is that also that while it's so effective, we can say that it's a kind of too effective microwave thermal ablation because it's very fast and also very effective in burning. So there is an issue in controlling to what extent you are burning just within the expected margin the tumor. Of course, there are clinicians which are excellent and very, very, very expert of this tool, and their experience allow to save many, many lives. But still, the point is that the treatment relies on the radiation oncologist experience, which means that there is a room for finding a way maybe to monitor in real time this treatment. Current modalities cannot do this again. Why? They cannot do it because, of course, they can do it, but with some, they can do it with some limitation. For instance, CT or cone beam CT cannot do it because of ionizing radiation, which means that one has to interleave the treatment with this. Or MRI has a problem of high cost, portability, and compatibility with the applicator, because the applicator is an electromagnetic source which put in an MRI can create noise. And finally, ultrasound, which would be the solution of election in some sense, is not possible to use that because the sensor is blinded by the vapor cloud which originates from the tumor when it's burned. On the other side, of course, I put this in green, but microwave imaging has all the advantages that can do it, and especially has a very, very strong contrast due to the fact that when the liver tissue change from ablated to pre-ablated to ablated, there is a huge drop due to the fact that we are removing water of the permittivity. This means that it's possible to image this change, and due to the fact that we are considering microwave imaging in this context, microwave imaging can be a technological solution. So we ran a very first proof of concept, I would say very rough, in which we just put an antenna on a piece of liver and we made an ablation. And of course, this is a rendering, but this is the cut of the ablation. You see, this is the tip of the applicator and the area. This is the burn area. This is the ablated area. This is the area where there is no ablation. And this image, you have to imagine that this is cut just in the plane of the antenna, is what we create here. And these two lines here, they correspond to this and this. Very, very low resolution, very bad, but they give us the hint that we could make an image of this kind in this very complex scenario. And therefore, we started designing a system ad hoc for this, with an antenna designed ad hoc in front of the abdomen. So we have skin, fat, muscle, and liver. And first of all, we identified the fact that we could not consider many, many frequencies, both due to the penetration and the fact that there was mainly the penetration. And the coupling medium, also the need of a coupling medium in order to improve the spatial resolution. So we design the system like this. We create the coupling medium in laboratory, use very simple, very simple ingredients. And this is the idea was that the medium should have 23 permittivity and 0.4 of conductivity, around 2 giga. And you see that this is what around between 1 and 2 giga. And this is more or less where we got that the permittivity changes not very much. The conductivity is a little bit lower, but it's okay. Then we design an antenna which was expected to work in the medium and set up a very first experiment in which you see this is a very preliminary one, but we need something more controllable than the piece of liver that we did in before. So we have an array of 4 antennas placed in front of a beaker, which was mimicking the liver, and inside the ablated region. So we made some, this is the coupling medium you see now, first without and then with the coupling medium. And here there are the targets here. And this is, okay, the properties of the different media to see that we are considering really media which look like what we are looking for. And these are the very first, very recent images that we have. This is the case when there is no ablation. This is when there is nothing in the tank, sorry. This is a kind of background which has to be subtracted for kind of reference situation. This is when there is no ablation, and this is when instead there is the ablation here. And we see that we are able quite well to locate and size the ablation. Of course, these are very preliminary things, and we are working on that, and we hope that we believe that this is a quite interesting topic for the medical community, and possibly the one in which microwave imaging can be really a useful technology. So this is basically my very quick, maybe, or maybe too fast overview about the topic of microwave imaging. I know it has been fast. For those of you who are interested in the topic, maybe you can have a look at the 2 books we have edited about the topic, which covers, especially because it's not only us. So there you can find out many references there, and many people working, maybe different point of view as well, because of course, as in any topic of science, people has different views and perspective. I need and I want, and I'm happy to acknowledge the colleagues I have developed all this work together, which is Professor Bellizzi from Federico II University of Napoli, Professor Marta Capagnaro from Sapienza University in Rome, Dr. Rosa Scapaticci from my institute, and Professor Francesca Pipiana from Politecnico di Torino. And I thank you for the attention. Grazie. And of course, I hope that there are questions and I am able to answer them.
Thank you, Lorenzo. Your talk was really clear. I say this very honestly because it's not my field, and I got a lot and very inspiring. You showed us a rainbow of applications. So thank you so much. I would like to invite the attendees to ask questions. You can also switch on your microphone. Turn on your microphone.
Paola, can I make a question?
Of course. Thank you, Matteo.
Thank you, Lorenzo, for the interesting talk. I'm completely new to the last application of microwave imaging that you presented, the one of monitoring microwave ablation treatment. So I have just a couple of curiosity. So the first is, how do you mimic the ablation process in the phantom? So you like physically insert the antenna in the phantom, and then which material you use, and how do you know that then the material that you are using is, say, ablated in the same way that an antenna would do in a real liver? And then the second question here is, how deep is the liver, and do you have enough penetration capability with microwaves to detect, let's say, a tumor ablated inside the liver?
Okay, thank you, Matteo. Thank you very much for the questions. So first of all, I mean, I would like to, there are two experiments I show you here. The first one, I would say the brave experiment we did, because this is a kind of wild one. In this case, we are really the ablation. So we really ablate the liver and look for that, because we wanted not to, let's say, mimic anything. We want to see what's going on inside the ablated liver. Can we see anything? It seems like this. Then when we move to this part, in this part, we take the results from the literature and try to match the result from the literature with our mixtures of salt, Tritonics, and distilled water, and they go quite well, I have to say. This is because, of course, this is mainly dictated now by the change in water content. So you can quite safely model the ablated. Of course, you will never have the nuance of a continuous change in the heat, but for what was this initial part was good. For me, once we realize that this is working, then we can say quite conveniently that we can move to, let's say, go back to the wild experiment and really ablate. There is no need to mimic a process, because when you do the ablation, then you cut and you can see the thing inside. So I would say that here there is no real modeling of the ablation process as it is, but only a change between liver and ablated liver. Okay, so we see this difference. As far as the penetration, of course, this was my concern. I was really worried about that. We made a number of simulations about this, and basically, in this condition, this seems, from this perspective, is not. But in the end of the day, the liver is quite not very superficial, because of course we have a layer of fat, we have the skin. But as long as we have a coupling medium which allows to, maybe I can show you here. I'll show you here. The point is the coupling medium, no? Because if you go by air, then you will have a lot of reflection, because there is skin, fat, muscle, and then liver. If we put a coupling medium, this facilitates the penetration, and this is why we kept a medium which is, we kept low the frequency, because you see, we can even consider, for instance, this range of frequency, because this is a kind of, you can see, it's the opposite of a semaphore. Red is okay, green is bad. So in the red part, we can go, but in the red part, if we have too high frequency, then the attenuation is too high. So we kept here as a trade-off, and therefore considered frequencies like 600 megahertz up to 1 giga, maybe 1 giga and a half, because those range of frequency provides enough reflection for a liver. Of course, this is there will be situation in which you cannot go enough inside, but there is one thing that I have to say, that assuming that you are able to measure the signal, which is of course a challenge, this is treatment. This is treatment monitoring. So you have a lot of information from very good and very assessed medical imaging modalities which are being used for treatment planning. So you can implement this in the microwave model, and then maybe recover some of the fact that you are losing with the attenuation. I don't know if I've been clear.
Okay, thanks. Yes, it was clear. If I can add just one thing. So in the end, this will be a differential imaging. So since if I
Yes,
got
it
you
is
correctly,
naturally. Sorry?
what you're aiming to image is the ablated area, is not the tumor itself. So
No, you know where the tumor is. You want only to see how the changes in the ablated area. So it's really differential. Also because you have to think that this happens in 1 minute. And in 1 minute, you have to take images. The real challenge here is to, this is why we made, with 4 antennas and so on. You need something which allows you to make the measurements and possibly the image while the clinician is doing the ablation. So it's really seconds. Okay.
Okay, thank you.
No, seconds is
when did you
less.
start working on this?
Sorry?
When did you start working on this? Is this very recent?
This is, you remember Menchu Wang?
Yes.
This was the thesis of Menchu as well.
Ah, okay.
But this part is not in the thesis. This is more recent.
Okay, thanks, Lorenzo.
Lorenzo, we have a question from Dr. Sumitra saying that I have experience solving forward problem in microwave tomography. I would like to gain insights to inverse problem. Could you give me some insights on approaching inverse problem for 2D imaging? I also would like to know how to approach to do forward problem used for 3D imaging.
I would say that the next webinar can be arranged about this. It's a very big. I'm happy you made this question because let's say this is my main my heart beats in the solution of inverse problems. I would say that I can address you to my to the literature. I would say you have to consider this. Okay, I would say go for our late friend Matteo Pastorino book. Check for that book, is really the best introduction for engineer for IMBE scattering problems. You are experienced in solving this equation, okay? When you know, so in this case, this one turns green, okay? So this problem is linear and well posed. An IMBE scattering problem, this one is red, so the problem is non-linear and ill-posed. So particular care has to be done this. But if you want to start with a really, really simple case, you can start with a linear problem. Then in this case, in the linear problem, you approximate the total field with the incident field and you put it here. And in this case, this becomes like a matrix inversion. But you have to be careful because this is an ill-conditioned matrix. And therefore, when you do this inversion, you cannot just do like in MATLAB INV. You have to do some more accurate things. So my suggestion is, if you have an experience in solving forward problem, create some forward model and then invert them with the linear model to start understanding what's going on. And of course, if you want to write me for advices, I'm happy to respond.
Thanks, Lorenzo. We have other two questions from Rocco Citroni, and I think they are the last questions because we are on time, but then we will run out of time. So first questions are related to machine learning. So how is machine learning being integrated into microwave tomography for improved diagnostic capabilities? And how can microwave tomography be combined with other imaging modalities to enhance diagnostic accuracy? And then there is another one. I say late. I tell you later. Lorenzo, you are muted. Oh. It's okay. It's okay.
Start from the last one. Okay, very nice question. Thank you. I didn't mention, I have to improve the seminar with this. There is some colleagues of us, especially in the US and in Canada, they are working together in combining ultrasound imaging and microwave tomography. This is a very good idea because, of course, there are this multimodality. There is also some other colleague in China and the US putting together thermal imaging and microwave imaging. So there are plenty of possibilities. I would say that and as long as we don't have microwave imaging in the medical community, then it's difficult to make really fair hybridization, but there is room because, of course, these are different physical parameters, different from ultrasound, different from CT. So we can take advantage of this. And again, I think that there are, as long as one gets the sweet spot of the different features of the different technique, one can only get an advantage of this. Of course, I look it from the microwave imaging point of view, but I think it's there is enough body of literature and technology now to work in this more comprehensive perspective. And as for the machine learning, I mean, machine learning is over anything in science nowadays. How use it in microwave imaging is another webinar again, maybe not by myself, but my other colleague working on that. But the problem is how to use machine learning in an inverse problem. So it's a big question. What I see as a kind of limitation in microimaging so far is that the machine learning techniques, they are data-based. And in microimaging, we have not yet enough data to be really relying on something which is driven by the data. So also this is because we don't have the data, meaning that we can make simulations, of course, but we have no real case data. And of course, as I show you, there is a very different imaging devices. So it's also different to take the data from different devices and putting them together. So I think that this definitely can be useful and can improve the solution of the inverse scattering problem, but still maybe the people interested in this has to look at this, considering that this is a data poor scenario. So very difficult for me to apply this. But important, not saying that it's impossible, say it's very important.
Thank you, Lorenzo. Now the very last question, again from Rocco. What recent advancements have been made in microwave tomography technology for cancer detection?
Okay, I try not to answer the use of nanoparticles because it's not really fair, but I think that one is a good idea. No, I think that one important advancement has been for cancer detection has been the understanding that it was not just like done in the very early days, going as far as soon as possible to the patient, but to design the system in such a way to reduce the uncertainties, deal with the model error, deal with the fact that it's a very complex scenario and we need an interplay between hardware and software. So if I would say maybe in the cancer, in the specific cancer, I think the advancements are more due to the fact that people is looking back to their system and making a redesign in order to have more enhanced accuracy. And this is possibly also done by the fact that the computational tools, the computational power is becoming such that maybe one can deal better with huge amount of data, because under this equation there is a huge modeling effort. And so maybe the fact that models effort are more compliant with modern computer is something we can deal with. I hope it was, but I don't know. I hope it was clear. Yeah.
I think so. I hope so as well. But yeah, I think so. So Lorenzo, what should I say? Really, thank you. It was a really nice talk. We learned a lot, and I would really like to thank you for your time, for the passion, because we could really understand the passion you put in all your research work. And if you already have idea of other possible seminars, so maybe.
Now I will just say I am happy for this. I've been very, very happy. Really is very nice, and I really again, but heartfully thank you for the invitation. And we think about new ones with other which are even better than me. Okay.
Okay. Sorry.
This is recorded and is available,
yes.
No?
Yeah,
okay,
I will make it.
We talk later. Okay.
Yes. Yeah, it's gonna be recorded. I would like again to thank you and to thank all the attendees. We had many attendees today, so it was a big success. And I wish you a nice rest of the day. Okay. Congrats.
Thank you. Bye-bye.
Bye-bye. Thank you, everybody. Bye-bye.